time, huh? Yes. Come on. Why don't you come? I'm going to come sit up here, or would you prefer to step up? You want to sit up here? Yeah, yeah, you should sit up. Yes.
Where would you like us?
Good afternoon. Hello, good afternoon. We're delighted to have your attendance here. Good afternoon. We will begin because we're just behind time a little bit already, and we want to give our great speakers an opportunity to share with us their work. I'm delighted to introduce Dr. Paul Spiegel, and he is the director of the Johns Hopkins Center for Humanitarian Health, and he's a professor in the Department of International Health. Prior to coming to the Bloomberg School of Public Health at Johns Hopkins University, he was part of the United Nations High Commissioner for Refugees in Geneva. He was the deputy director. And he has received numerous awards. We are delighted. I believe this may be your first time attending our conference, Dr. Spiegel, so we're delighted to have you. We're also delighted to have his daughter joining us today, too. So without further ado, I'd like to give you the opportunity to share your work with us. We're switching up the program just a little bit. We will take questions right after his lecture for 5 minutes, and then we'll proceed with the next speaker. So thank you.
Hello, good afternoon, everyone. Let's see where the slides come up. So it's a pleasure to be here, and I hope that given the current situation in the world right now, I hope that you'll find the topic topical. Oh, some of the slides are cut off, but that's okay. We'll fool around with it. No? There we go. You fixed it. Thank you. Okay, so thank you. So I have about 25 minutes or so, and then we'll take some questions. And I want to talk about HIV and conflict and forced displacement today. Some of the perceptions and reality, and we'll start back in time and then move forward to now. So I'll talk a little bit about the magnitude of the forced displacement, the perceptions of HIV and conflict and displacement, and where did some of these myths originate, the evidence for it in the 1990s and early 2000s, a study that we did in 2007 that I think had an effect on perceptions and what happened afterwards, and then we'll talk about some of the policies and interventions. So the magnitude of the forced displacement, and every time I see this photo, it's extraordinary. It takes place of a Palestinian refugee camp in Syria in 2014. So we currently have 65.6 million forcibly displaced people at the end of 2016. So in 2016, 10.3 new people were displaced, which ends up to be extraordinary, 20 new displacements every minute. But when you look at the breakdown, and the key here I think is forcibly displaced. We're not talking about economic migration. We have about approximately 22.5 million refugees, 40.3 internally displaced persons, so those are people that have been displaced because of persecution, conflict, violence, war, but have not crossed an internationally recognized border, and they are the largest group out of these 65.6 million. And then finally, 2.8 million asylum seekers, and these people are people that have sought asylum and will hopefully get a refugee status or not. And then if they do not receive a refugee status, they don't get the rights of a refugee and will often be returned home. And we're seeing this in Europe and many other countries right now. So what are some of the perceptions of HIV and conflict and forced displacement? They weren't very pretty, and in 2006 in UNHCR we decided to do this booklet, a cartoon booklet, to give to governments, NGOs in the field to try to to try to advocate for refugees' rights. And we've seen it consistently that refugees are considered people that bring in crime to a community, that spread disease. Yet there's very little evidence that this is the case. And of course, sometimes that may be, depending on the context. And there are some reasons behind it. And so we developed this booklet to share primarily with people dealing with refugees. So if we move back to 1996 and this paradigm of human security, actually it started with in the Clinton administration, and it was a reorientation of US policy towards security threats. And they converged on HIV/AIDS as a human security threat that posed dangers to militaries, but also threatened state failure. And if you remember back to this time, there were a lot of concerns that states would actually implode, starting in Southern Africa and then expand globally. And then in 2000, the US National Intelligence Council prepared its first ever assessment of security posed by infectious disease. And again, they singled out HIV. And this was an impetus with Richard Holbrooke for the UN UNGAS on UN General Assembly Special Resolution on HIV in 2001. And then finally in 2003, you may remember, but the Secretary General Kofi Annan warned of a triple threat: HIV, food insecurity, and government in Southern Africa, again with apocalyptic sort of warnings of HIV at that time. And so in the declaration in June 2001, Article number 12 said, noting that armed conflicts and natural disaster also exacerbate the spread of the epidemic. But is that true, and where did all of this come from? So it was interesting, and again, preparing for this talk, I went back in time and trying to look at some of the original articles. And there were not, in the early 1990s, there were not many articles on HIV and conflict and their vulnerabilities and risks. And there were a couple articles that were just, the data were not correct, or there was so much bias that I removed. And so I found two articles that I want to show you. One is this one by Smallman, Raynar, and Cliff, that looked at Mozambique, and this happens to be in, I'm sorry, I'm ahead of myself. This is where the myths started. And so I ignore what I just said. Here, this is one of the first articles that came out in 1991 looking at Uganda. And it was a very, very interesting article at the time, but there were very limited data, and they were not looking at prospective data and data over time and trends. And what it found was that, and the wording is key, and I've underlined it for you because of the way it's been used in the future. So it says, we therefore tentatively suggest that the apparent geographical pattern of clinical AIDS in Uganda partially reflects the diffusion of HIV associated with civil war during the first 6 years of the post-Idi Amin period in Uganda. And it was a good article, but they knew tentatively the data were not so strong at that point, but it was an hypothesis. But this was taken, let's see if I can get, by the World Bank. There we go. In 2003, Paul Collier, and many of you know him, in Breaking the Conflict Trap. And what they did here is they quoted only this article, but they said the origin of the global pandemic is a consequence of a particular civil war, and they were referring to Uganda, again on data that was very suspect, and the authors that wrote it recognized this was just a hypothesis. And then the last one I want to show you is the World Vision Report, and again it was an excellent report called Pawns of Politics, Children, Conflict, and Peace in Northern Uganda in 2004. And this report had a very big effect. But what it said was that if you look at the 18-year war between the Ugandan government and the LRA, the HIV in parts of the north where there's been conflict is 11.9%. This was in 2003, nearly double the rest of the country. And what we've seen consistently is people are either talking about one point in time, or they're not putting the data in context. So if you look here, I'm going to try to see if this works. Yes. So if you look here, this is the trend line of HIV prevalence from 1991 to 2003. And this is Gulu, the green line here, and it's 11.9% in 2002. And then you look at the national average, and it's in 2002 it was about 4.9. So indeed there is a doubling. But when you look at the trend line in northern Uganda, as well as some parts in northern Uganda, non-northern Uganda and peaceful parts, it follows the same trend line, and you can see clearly that during this time, HIV prevalence in the areas where there was conflict and where there was not conflict has been decreasing. So these myths and this anti-refugee discrimination still exist today. In 2011, I was responding with UNHCR in Côte d'Ivoire, and this was the Ivorians were actually displacing to Liberia, and you can read this in the Liberian paper at the time, that's saying that the refugees are getting enough aid, and he's also heard that a good number of them have AIDS to spread. It's not uncommon, and as we see right now in the populism that's occurring in many parts of the world, in the US, in Europe, you see still a tremendous amount of anti-immigration, anti-refugee rhetoric, much of it not based on good data. So what was some of the evidence in early 1990s and the 2000s? This was the article I was referring to. Out of many articles that I read at this time, and well, some articles, because there weren't that many, and the quality was suspect of many, but here are two that I think have an inkling of what we have found in our larger study. So this was from data from 92 and 93 in Mozambique, looking at internally displaced persons. And they found that the HIV prevalence, and this was using antenatal sentinel surveillance sites, which is much of the data that we have with refugees and displaced persons. And we found that the HIV prevalence was very low in this group, and the authors suggested either that there was a recent introduction of HIV, or in this area, a slow spread of the epidemic, which again is the first hint that conflict may not be actually exacerbating HIV. This similar group, in 1994-95, they followed the Mozambique refugees into Swaziland. And again, as we know, Swaziland has a very high HIV prevalence. So there are a couple things we learned here, that the refugees had a low HIV prevalence from Mozambique. They moved into Swaziland with a high HIV prevalence. And then depending on where they were located, the refugees, and they were from a similar area, so the refugees had very different, even though it was lower than Swazi HIV prevalence, they had very different prevalences of HIV. Those that were nearer in a populous area interacting with the host community had a higher HIV prevalence than those that were in the more remote areas. And so with this information and some of the work we had done at Centers for Disease Control, we decided to start and say, well, what is the evidence? And this was around 2004, 2005. So I'll try this again. We looked at countries. So there were 29 countries in 2000, the year 2000, that had refugee populations, and then Asia. And this is where they came from. So this is the country of origin and then the country of asylum. And we weighted according to population size. And none of this, of course, is causal, but it does show in Africa in particular, where you had conflict and people left, that the HIV prevalence overall was lower and they were moving to an area of higher HIV prevalence. We didn't see much difference in Asia. We saw an increase, similar thing in Europe, and then there were smaller groups in Latin America and North America that had the opposite. In North America, it was easy to decide because a lot of the refugees that would come there would be from higher prevalence countries. Then Nancy Mock from Tulane just did a simple overlay of the war. This was again data from 2000, I believe, or 2001, and she looked at the wars and the conflict in Africa, and she overlaid with the HIV prevalence using UNAIDS data at the same time. And again, you can clearly see that the dark on your left, where you have major wars and major conflicts with 100,000 plus casualties, highlights onto a lower HIV prevalence. This came out a little bit later, unfortunately. It came out in 2007, but the data were from 2000, showing that previous slide in a different way, but the higher the HIV prevalence and the level of armed conflict are inversely related. And so the HIV prevalence is higher in areas that have had low armed conflict. And so what we wanted to do was to look at the existing data and then try to look at how we can use the data to change policies and advocate. just looking at my timing. So in 2006, with UNHCR and some other groups, we started to look at what existed, and what we decided to do was look at the peer-reviewed articles, those that existed. We had undertaken at HCR over the last many years antenatal sentinel surveillance in refugee camps, primarily in camps themselves, as well as undertaking some larger population-based surveys. And then we had some other data from Médecins Sans Frontières and other groups. So we tried to collate it all, look at the quality of the data, and then try to interpret of what we were seeing in terms of conflict and then movement of refugees, and comparing countries that had been in conflict for a long period of time to the surrounding countries that had not, and comparing refugees, where they're situated, to the nearest antenatal sentinel sites of the host communities. So here's some examples. What this is looking at in 2003 and 2004 in Democratic Republic of Congo, there was a population-based survey of HIV, and we're looking now at the eastern part of DRC that had been, has been, and continues to be in conflict, unfortunately. And I'm cognizant that so you see confidence intervals because this was a survey, but we're comparing it to antenatal care sites, the nearest sites. So we're not comparing apples to apples, and there are biases when comparing population data of HIV prevalence to antenatal, but generally the antenatal are considered lower. And so one can think about that on your right-hand side, it may actually be a little bit higher. And what we find is a variable, but we find for the most part the Congo sites where we have measured compared to the surrounding nearest site in the nearest country is either the same or lower. And so if we look, we saw 3.1% in Bukavu, and in the Burundi sites we see significantly higher. And you can go all the way down for the most part and see that in eastern Congo, where the conflict has been raging, the HIV prevalence is lower. Furthermore, this study showed, although they didn't discuss it openly, but when you compare the western Congo to the east of Congo, you actually didn't see a statistically significant difference, despite eastern Congo being in conflict for so long. Let's see if this works. Okay, so then what we did, and this is the last major slide with data for you, is then what we did is we wanted to look at the refugees. So you can see in each of these, the top one is the Burundi refugees in Tanzania. And we either had antenatal sentinel surveillance for HIV prevalence, and then we used, again, the nearest antenatal site in that country for the host communities so that we could compare refugees to the host communities. And you can see relatively consistently, I'll try to use the pointer here. The first one, so we had refugees in Mitimbile and Myovosi, and you have this is quite a difference in 2 years. We're not able to explain why, but you see actually it is higher. So the refugees had a higher when you compared. But all of the other ones, we see 1.3, 1.6. It's very similar. I wouldn't say big difference there when you compare. We had Lukoli camp. When you compare 2003, it was lower. We have the camps, DRC refugees in Tanzania, lower than in the Kagera region. And this was very interesting because in Rwanda, we were able to, with the Rwandese government, undertake a population-based survey of the refugees and a separate one of the nationals right beside. So there is an apple-to-apple comparison, and we did find that there is a lower amongst the refugees. And as we move to southern Africa, in Zambia, for example, we see a very big difference, and this has been consistent. And the Eritrean refugees in Sudan was very similar. So part of the conclusions, and we'll get to them, is that we don't have evidence that conflict is actually exacerbating the situation, and we have a fair bit of evidence to show that conflict may actually be protective. But it's going to be very context-specific. So these are some of the big areas that we would like to look at, that we believe one needs to look at when dealing with conflict and forced displacement. So number one is the HIV prevalence at the origin of where they are, and try to go as disaggregated. If you can get to the provincial level, it's much better because obviously within a country there are huge variances. Look at the HIV prevalence in the host area to where the refugees are fleeing. The length of time of conflict is very important, we believe. And I didn't mention this, but on average, a refugee is a refugee. The numbers vary. It used to be 17 years, and now it's down to about 10.3 years. But the point is that a lot of people think about humanitarian emergencies and displacement as short-term, acute emergencies, the bombs falling, people dying. That is, of course, the case in the acute phase, but a refugee remains a refugee for over 10 years. And so we need to think in a development-like way. And I'll get to that when we talk about antiretroviral therapy. So some of the decreasing risks in conflict situations specifically that we believe had a major effect was a reduction in mobility. Because of the war, people weren't able to move around as much, a slowing of urbanization, and also an increase in poverty, which could have a major effect in terms of movement, in terms of concomitant partners. If you look on the red, you see some of the increasing risks, and I think a lot of people focused on these increasing risks, understandably. Increase in sexual gender-based violence during conflict is quite large, but one has to look proportionally, particularly in cases of rape and the transmission of HIV due to a sexual act, even if it is a violent sexual act, and the numbers of a population that we're dealing with, as well as a lot of behavioral changes and coping mechanisms. And then the latter two depend. Increasing resources, increasing accesses to host area may have increasing accesses to, but in conflict situations like in Syria and in Central African Republic, we're seeing a reduction in resources and a reduced access to services. And you almost have to take all of this and weigh all of these factors to see which way we may be going. So here's some other, after we published this in 2000 in The Lancet, there have been about 3 or 4 other articles that have come out in Angola, another one in northern Uganda, another one looking at refugees and migrants living in Thailand and comparing them to the Thai hosts together with the non-displaced Burmese in Myanmar. And then most recently again in Uganda, the refugee camps, all showing that refugees had either the same or lower prevalence than their host communities. So some of the key conclusions from this, and I have a couple more slides after this to talk about next steps and what we did with this information. But that individual vulnerabilities and risks exist for persons affected by conflict and forced displacement. However, this does not necessarily translate into increased HIV infection at the population level. Number 2 is that refugees appear to have lower or similar HIV prevalence to those of the host community, and that all of these situations must be examined according to context. And this is what I've learned consistently, both in terms of refugees and in terms of HIV. When you make suppositions that, because it would be a normal, you would think, okay, conflict, sexual gender-based violence, poor services, HIV is going to increase. And I'm not saying that that's not the case. It may occur in certain areas, but many of these conflicts, particularly in Africa, had been going on for decades in Sudan, now South Sudan, Somalia, and likely the conflict and some of these factors that decrease the context probably kept the HIV relatively low. In Ivory Coast, that was different. Ivory Coast, and we've seen in Africa itself, that HIV prospers in wealthier countries and often amongst the wealthier, or certainly when there's a divide amongst the income. So Cote d'Ivoire and the refugees moving to Liberia or Sierra Leone actually could have an effect, because there, Cote d'Ivoire was a well-off country and the HIV prevalence was higher than the surrounding countries. Try to go back one. So the next supposition is to say, well, what could happen? Does HIV and infection spread in the post-conflict phase? And this is still a question. I don't think we have enough data yet to know, and we were trying to look at Liberia and Sierra Leone. Certainly in Mozambique, after the war, the infections did increase, but whether that is due to what this author called a paradoxical piece, or whether it's due to other factors is still not known. So I think this is an area that could be looked into, but certainly post-conflict, a lot of money coming in, roads are being built, more and more jobs. There's a likelihood, there's a way of thinking that this may occur, but we don't yet have enough information. The other area is, do refugees, and this is something we've been trying to answer, do refugees adhere to antiretroviral therapy, and if treatment outcomes similar to host nationals? In 2004, when we started, refugees, it was considered that we shouldn't give antiretrovirals to refugees. They weren't included in any national programs, and the Global Fund and others weren't even looking at refugees in conflict. Over time, and these are just some papers that we've published in the last while looking at refugees, because there are not many, there are about 7 that have actually looked at refugee adherence. And as I mentioned, we're not talking acute phase, we're talking more in the chronic phase. We've seen something interesting. In Kuala Lumpur, the refugees had a very high antiretroviral adherence rate, similar. There was no statistical difference between them and the host nationals in that area. In Kenya, and this one was just published recently, in Kenya we looked in Kakuma refugee camp in the north with South Sudanese and Somalis. We found a very low antiretroviral, an ART adherence rate, but interestingly the nationals had the same rate and the same problems, which were more community focused. So we need more and more of these studies, but Doctors Without Borders, Médecins Sans Frontières have done studies as well to show that overall antiretroviral therapy amongst refugees is similar to the national population, and it should not be used as an excuse not to provide antiretroviral therapy to these populations. So briefly, some of the policies, interventions, and outcomes. UNHCR joined UNAIDS in 2004, and that was actually a very big deal because before that there were only 10 or 9 co-sponsors, and none of them were dealing with conflict. So with some of the data that we were gathering, we had an international stage to try to push this in terms of advocacy for refugees, to say that we don't believe that refugees are actually vectors of HIV transmission. In fact, quite the opposite, may need very strong prevention programs because they may be surrounded by people that may have higher HIV prevalence. But we also talked about the protection issues of refugees. And so with UNAIDS and with all the co-sponsors, we were able to get this issue out to the fore. Now with the UN, of course, we published a lot of guidance, but we think some of the guidance has had a positive effect, and I just want to mention a couple. Number one is the 2003, with the first guidance looking at HIV and humanitarian emergencies and fitting in HIV into all of the different areas, because it was still being medicalized in the humanitarian and thinking about health. But the discrimination, the protection, the legal issues were not being discussed at that time. So we made sure in every sector we had, from food, from nutrition to shelter, we had a component with HIV. The other area, if we look on 2007, is UNHCR came out with an antiretroviral policy for refugees because nothing existed, there was no guidance. And we tried to show clearly that refugees need antiretroviral therapy, and also, and I'll move to the next one, and if you look at 2014, but we had one earlier, we tried to adapt WHO's policy for providing antiretroviral therapies for the conflict situation. So we would recommend, for example, not giving people that are either refugees or living in fragile states 1 month doses for antiretroviral therapy, but give longer because they have to move. We would recommend, and Doctors Without Borders was very important here, to decentralize stockpiles, because we found at times conflict, and if they were all in one area and it was inaccessible, suddenly there was no access to ART. These are just some examples. What we also did is we did an advocacy to look at inclusion of refugees, host countries' HIV national strategic plans. So in 2009, less than 50%, 48% actually included refugees in those countries that had greater than 10,000 refugees. By 2013, it had increased to 87%. And that was the first step in order for them to get funded. We also were able to increase, this isn't necessarily provision, but it was part of their policy to say that refugees should have access to antiretroviral therapy at a similar level to national host populations. And this was also, we advocated for this for PMTCT. And so in 2010, only 79% of countries with greater than 10,000 refugees in sub-Saharan Africa had this, and it moved to 97%. We also, through concerted effort of behavioral surveillance surveys, we were able to measure some of our programs that we worked with national governments as well as international NGOs and national NGOs. And we did find in 10 countries, we found a reduction in in high-risk sex and improved HIV knowledge amongst refugees who had been under the various programs. I hope this is my last slide. It is. So my last slide, before I take some questions, is really some final thoughts are not to make assumptions, even if they seem logical, to really collect data and actually collect quality data, because we've seen consistently, and I'm sure it's not just for refugees, bad data or data that are preliminary and that then are being used to actually make decisions and affect people's policies for decades. And when you go back and you never accept one data point, for example. Go back to the original data and see where it is. And when you start looking at that, you may be surprised that either the data was poor or was just one study and it becomes fact. And finally, we found it within, when I was at UNHCR, and what we're trying to do at Hopkins is to use data to make evidence-based decisions. And we're trying not just in the HIV field, but we're trying with the US government and the various decisions that they're making in terms of travel. We're trying to bring evidence and show evidence that the policies that they are making are not based on evidence, and therefore they should be using evidence to try to make these various policies. Sometimes it works, sometimes when politicians don't want to hear, they won't listen, but at least we're putting it out there for everyone to hear. So with that, thank you very much.
So thank you so much for sharing your work, showing context matters, and certainly the use of data and science to debunk alternative facts, which I think is something very much on a lot of our minds. We'd like to take questions now for Dr. Spiegel. If you would come to the mic with your questions. Oh, please. Sorry, I didn't see you. Yeah. Here. Your mic is not on.
Okay. Thank you for that talk. I really like the point about not making assumptions, even if they seem logical. And I appreciate that you were primarily talking about refugees and whether or not they spread HIV. Did any of your work come across data or ideas about armies, particularly peacekeeping armies and so on, and whether or not they may have spread HIV at all?
Should I take a couple or just one more? Yeah. Yeah, we did look at that, and particularly in those early years, it talked about peacekeepers spreading HIV. The problem, so we looked at this, and we even did a controversial piece, which I half regret doing, looking at rape and the spread of HIV through rape and conflict. And the bottom line is that when you start looking just at the statistics and remove the emotions, the peacekeeping forces are relatively small compared to a big population. So there's no question on the individual level, there were increases in HIV transmission with peacekeepers, there's increase in HIV transmission amongst women and men who are raped, but at a broad country level population based, it probably has very little effect.
Thank you.
Charlotte Gators from Johns Hopkins. That was a lovely lecture and a lot of thought, a lot of things to think about. I have two questions. The first one is, have you ever looked at any STD rates among refugees, like for syphilis, for example, which is pretty easy to measure these days? And the second question is, do you have any evidence that providing the antiretrovirals is effective? Are they adherent, and do they indeed lower their viral load?
Yes. So for the first one, STD rates, we are actually working on that, a large study on that, and I'd hoped for it to be ready this time, but it was not. But we have seen, for instance, that first one, interestingly, in Mozambique in 1992, the syphilis rates were high, but the HIV rates were low. But we're going to be looking at that more, so I don't have that answer for you. In terms of the antiretroviral therapy, yes. So in both Kuala Lumpur and also in Kakuma, we measured not just pharmacy refills, but we measured the viral loads. And what we found was, as I said, they were similar to the host population, but in Kuala Lumpur, the viral loads were very low, and it was well over, I think it was 92 or 93% adherence, and we were able to follow the outcomes, which were good. In Kenya, they weren't very good. That was a while back, and we started particularly community-based. We thought it was much more in terms of community-based approaches. There are only 2 or 3 other studies that I'm aware of, and one is in Uganda in the refugee camps that also did viral load and found a very high adherence and low viral load.
Thanks. Thank you for an informative talk. My question is about the transition from, you really talked nicely about the need to deconstruct the ecological evidence, these sort of association data that were historical data. But I wonder, in an ideal world, knowing that these events will happen again, what kind of systems would you ideally see in place that would be put into motion as these events start to collect more prospective data and move beyond that ecological piece? So what would your wish list be for a proactive system to understand what's going on when these conflicts arise?
Yeah. Thank you. Excellent question. Definitely a big wish list, but we haven't been succeeding with donors on this. Firstly, in emergencies to begin with, it's extremely difficult to, and we're talking now the acute emergencies, it's extremely difficult to measure. Forget just HIV prevalence. At times we're having trouble measuring simple mortality in some of these areas. You know, if you look in Syria right now or in Yemen, we're having estimates, but things are changing because of the technology, and particularly because of the cell phone technology. So what we would like to do, and this would be a start, and I was just talking to someone about this, but it's complicated in in any setting, but it's particularly complicated in refugee settings, is to start having mobile records, or let's say electronic records, that we would be able to look at. And the biggest problem that we're finding everywhere in the world, but it can be more dangerous in refugee situations, is protection issues. And what happens if those data, HIV, TB, get into the wrong hands? We have many countries, and I didn't discuss that here, that have HIV restrictions. So if you're not a visitor, but even if you're even visiting the country, but if you're a refugee and you're found to be HIV positive, you will be refooled. You will be not allowed to stay in that country and move back. And that's a major, major problem. And so I think that would be one of the ways to look at this, is to be able to do better testing and then have that data electronically. But I don't think that's going to happen anytime soon. Thank you.
I'm sorry, we don't have time for another question, but thank you so much. Please join me in thanking Dr. Spiegel.
I'm Basil Donovan from the Kirby Institute in Sydney, and it's my pleasure to introduce to you Alex Garner, whose title is Senior Health Innovation Strategist at Hornet, the premier gay social networking app with over 15 million users worldwide, and quite a few in Brazil, I understand. Alex is going to enlighten us on using the power of dating apps to aid the prevention of HIV and STIs. You have the chair.
Thank you. Let me see if this PowerPoint comes up. Okay. Give it a second. Here we go. Great. Thank you. And before I begin, I want to extend my thanks to the conference organizers for the invitation to speak to you here today. And I thank you in advance for your attention during this 25-30-minute session. I will anticipate asking for some of your participation. So I guess the first question that I would like to ask is how many of you out there, just by a show of hands, have used an app for dating? That few, okay. Well, we need to get some more of you hooked up to some apps. So as mentioned, I'm the Senior Health Innovation Strategist at Hornet, a gay social networking app. I'm going to give you a little background on Hornet, what we do, some of the activities we've participated in with different organizations around the globe, as well as some of the potential to engage gay men who are using social networking apps. So as mentioned, Hornet is international gay dating app. We now have 20 million users globally. We have 250 million in-app messages sent weekly, 500 million plus collective minutes across the global gay community, and 2 million plus ad impressions monthly. So if there's any question about the sort of time and ubiquitousness of gay dating apps among gay, bisexual, same-gender loving, and men who have sex with men, I think most of us know that they're quite common in our experience, and particularly in regards to our sexual health. As I mentioned, Hornet is a global company, so we have offices in 10 million locations around the globe. I'm sorry, 10 locations around the globe. Maybe one day it'll be 10 million. And the app itself is offered in over 27 languages. We have 70 plus, it's constantly growing, 70 plus team members situated all around the globe. And we have about 5 or 6 here in the Brazil area. So there's 3 different elements that are important to keep in mind in terms of the social networking app that Hornet provides and the community that we've created for gay men around the globe. So one of the first elements is that we're a social network. So we allow men to make meaningful connections with one another based on their geographic area, to meet other men, to create a profile, and to engage with one another for all sorts of meaningful connections, be that a chat, a date, a hookup, what have you. We also have an element called Places. Places is a gay guide, a city guide that's curated by a database of 300 cities in 70 countries. It's become a go-to guide for different locations and spots around the globe. From a health perspective, it becomes particularly important because we're in the process of integrating testing centers and LGBT health centers so that men can find the nearest spot to go in for a test or for some health care in their region. The third element to Hornet within the app we have, it's called Stories. So we have an LGBT newsroom that creates content for our users and for the larger community, covering news, politics, cultural events, and entertainment. And it provides a great opportunity in terms of how we engage and tell the stories in terms of gay men's health. So stories involving living with HIV, taking and accessing PrEP, or working to reduce HIV-related stigma. So one of the elements that's key to the experience within the Hornet app is a feature called Know Your Status. So when you create a profile on Hornet, one of the things you have the option of doing is creating a profile where we ask you to select an HIV status. So you can select negative, negative on PrEP, positive, positive undetectable, or don't know. And when you do that, we also ask you to enter the date of your last test if negative, or your last engagement in care if positive, and we automatically remind you in 6 months that it's time for a test or to engage in care. And whoops. The Know Your Status feature really allows users the opportunity to express their HIV status to one another. So this allows not only users to sort of jumpstart the conversation about HIV prevention, but it also has an impact in terms of the stigma that gay men face around their HIV status. So the idea that you can find someone in your area, you can see someone in your area who's also HIV positive can have a profound impact on what it means to be living with HIV. So for example, it's one thing to know that there are other HIV positive people around the world, but it's something entirely different to realize that that person lives down the street or around the corner or in the same city in which you live. And there's the ability to really foster a sense of community for our HIV positive users. And one of those elements that we wanted to be able to highlight in terms of that experience has to do with a recent video that we created. So I'm going to share that with you if technologically everything goes as it's supposed to. We just needed some duct tape. So the impetus behind creating a video like this was really to be able to highlight the experience that HIV positive gay men have within the online app world. It isn't meant to be a public service announcement or an educational video. It's simply meant to be marketing to reflect the experience of people living with HIV, which is something we haven't really seen a great deal of in our marketing or in the narrative around gay dating apps, often it's very much focused on the bad experiences that people living with HIV face and the stigmatizing language and words that they might encounter. At this point, you're probably wondering who I am in terms of why am I explaining all of this to you. And just to give you a brief bit of background on me, I've been working in gay men's health for over 21 years. I've been HIV positive for over 21 years. And it's really been central to me to be able to advocate on behalf of gay men and to amplify the voices of those of us in our community around so many of these issues. So we were really fortunate in the past year to work in collaboration here in Brazil with the UNAIDS, the Health Ministry of Brazil, and UNESCO around an initiative for the Olympic Games and the Paralympics. So what we created in collaboration with them was an initiative called Clocerto, forgive my Portuguese pronunciation. And essentially, this initiative was centered around the peer engagement of men within the app. So what we saw happening within the app is that any one of you who have used an app in the past maybe have experienced this, but it's very common for someone within the app, a man, to reach out to another man within the app for information, for questions around health-related issues. So whether that's PrEP or PEP or living with HIV or HIV treatment, it was something that we saw consistently happening between men, between peers within the app. And so we created this initiative as a means to provide some structure and to help facilitate those conversations. And one of the things that we found, aside from the ability for peers to engage with one another and to provide useful information about where to access resources, about the lived experience of having to go in for a test, having to access PrEP, having to deal with an HIV diagnosis, is that there was a multi-directional benefit. It wasn't just an individual who talked to someone else who gained some information, but it really had an impact on the individuals who volunteered to be what we term to be health ambassadors. So these health ambassadors were functioning to provide a benefit to their peers who were other users, but they also experienced the benefit of being able to contribute to their community, to make a connection with men. And so hopefully this will work. As well. Maybe we need some help with the audio. Mm-mm. Nope. Okay. So I'll give you a brief rundown of the program that we did with Brazil's Health Ministry, UNAIDS, and UNESCO. And it's unfortunate that you can't see the video only because now I think we've lost the entire screen. Here we go. Because one of the things that was great to be able to highlight about this video was that we heard from the volunteers in the program talking about the number of men they engaged with, the interactions, the questions that they got. Many of the questions were around PEP. The questions were also around living with HIV. We had a number of the volunteers who were openly HIV positive within their profile that was able to engage with gay men in Rio and the surrounding areas around living with HIV, around accessing treatment, and really around dealing with so many of the issues having to do with stigma that associate living with HIV. And so one of the things that I wanted to mention in regards to stigma, which is an ongoing issue reported by gay men using dating apps, is stigma is something that is learned. Stigma is something largely learned within gay male communities from HIV prevention and public health. And here are a couple of examples of particularly stigmatizing HIV prevention campaigns that have been out around the world, focusing on comparing AIDS to murder, or stigmatizing the experience of people living with HIV as a form of prevention, or focusing on gay men of color as victims in the HIV epidemic. And I think one of the sort of key things for us to keep in mind, whether it's around HIV or around STI infections, has to do with this sort of ongoing need to assign blame to someone. So often, when you tell someone that you're HIV positive, the first thing they ask you is, who gave it to you? How did you get it? And there's this constant investigative need to assign blame to someone. Actually, just this morning, I read a piece on BBC News talking about gonorrhea and antibiotic-resistant gonorrhea. And the woman from the World Health Organization said that antibiotic-resistant gonorrhea was due to gay men's sexual behavior in the United States. So what I would like to propose in terms of how we think about STI and HIV prevention and transmission is to really challenge ourselves to think how we frame when HIV and STI transmission occurs. So there's often an element of paternalism and protectionism by a health department when trying to figure out how STDs happened, STIs happened, monitoring and surveillance, as opposed to creating a culture where gay men have regular access to STI treatment and prevention. How many people in here are willing to say that they had an STD at any point in their life? So statistically, that would be a radically small number to most of you who understand the statistics related to STDs. How many of you had a cold or a flu last year? A significantly larger number of hands. So I guess the point that I'm trying to make is, if you look at the mortality rate for gonorrhea versus the mortality rate for cold and flus, it's radically different. Yet the way that we treat a cold and a flu, we don't ask you who you came in contact with. We let you go home. You can get on a plane. You can fly all the way around the world. But if you have gonorrhea, we ask you to give us a list of your partners. We want to surveil you. But thousands of people died from the flu last year in the United States alone. And so the main difference between that, obviously, is that sex was involved. And so I think that it would be this radical notion to think about how we reframe STIs in the same way that we created this sort of cultural narrative around cold and flu season, right? So we've adjusted the culture where people sneeze into their arms. We've adjusted the culture where people are using Purell. You have an entire office culture dedicated to cold and flus, but we haven't done the same thing around STIs. And the main reason is because it has to do with sex. In particular, gay sex. So in terms of apps like Hornet and how we can work in regards to not only helping to reduce the stigma related to HIV, but also providing these meaningful connections for men around the world, is that we can work in concert with various community-based organizations, various health institutions, and various universities to provide research and to conduct surveys. So here's an example of a survey that we did last year around PrEP in the European region in collaboration with the European CDC. And so you see here, this is sort of an indication of men's interest in PrEP at a time where it seems like it was very long ago, a year and a half ago, yet 30% were likely to use PrEP within the next 6 months. And that same study we're replicating right now in the European region to determine how much these numbers have shifted. One of the things that is a key indication is we asked men in the survey, and there were nearly 10,000 respondents in this survey. We asked them if they gained information through the Know Your Status feature that we mentioned earlier, and 30% of them said they did. So 30% of those respondents gained some health information from a feature that we have within the app. So that's one indication of the potential that apps like ours have in terms of distributing information that can be useful as gay men make decisions about their sexual health. A project that we worked on with an organization in Turkey, the Positive Living Association, they published a piece in the International Society for Infectious Diseases where we helped them recruit individuals to take part in a survey. They would come into the center and they would get an HIV test. And Turkey is considered a low incidence country for HIV. But what they found is of the 197 that came in for an HIV test, 12.7% were positive. So while that may not be surprising to most of us who work in HIV, it was surprising in a country like Turkey, which is considered a low incidence state. But it also allowed us to engage with hard to reach populations, to connect them to this community center, to come in and get tested and linked to care and be counted. And being counted is important both from a humanitarian standpoint and from a basic funding standpoint. And I think the future of gay men's health really has to do with how we can shift how we talk about HIV transmission in terms of gay men, how we can shift how we talk about prevention options like PrEP. And I wanted to point to this particular campaign that came out of ED in France that has to do with undetectability. And there's still quite a few men and individuals around the world who don't have a basic understanding of what it means to be undetectable. And one, it's incredibly important to be undetectable if you're HIV positive. The primary function of that is to maintain your health and longevity. The secondary function is that the chance of transmission is virtually impossible. And not only does that have a profound impact on prevention, but it has a profound impact on the way that gay men can relate to one another in the context of a disease that we've been living with for 36 years. And then finally, one of the things that I wanted to challenge us to think about was how we think about the world of gay dating apps as not just a piece of technology, but a community. So within these apps, we're creating a community so that gay men can connect to one another, whether they're living around the corner from one another or whether they're living halfway around the world from one another. And it also allows for us to create a community that's affirming, that's empowering to gay men, regardless of HIV status, regardless of ethnic background and diversity, regardless of gender expression. The communities that we create within an app are a community of our creation. So we can get out of it what we put into it. And so for us, we're very dedicated to being able to create a community that is health-focused, that is sex-positive, and that allows gay men to have as much information as possible so they can make informed decisions about their health. And for our experience with community-based organizations, with health institutions, and with educational institutions, we see them as critical partners in helping to disseminate information to gay men, and helping to engage gay men around their health, around sexual health, around the latest in HIV prevention options, as well as working to reduce the stigma that's related to living with HIV, or simply the stigma related to the sexuality that gay men experience. And as was mentioned in the previous presentation, we also have the unique opportunity to engage with gay men who are living in environments that are quite hostile. And we know that that can have an impact on their health. And we also know that HIV and homosexuality are still criminalized in dozens of countries around the world. And the idea that as gay men we're criminalized, or as people living with HIV are criminalized, that has a significant impact on how we can engage those populations in care. And it has a significant impact in terms of how gay men can connect to one another. And so in regions where there isn't a community center, there may not be a gay bar, there is a telephone and a mobile app. And that allows gay men to connect with one another. It allows them to connect with important health-related resources. And it allows them to build a sense of community, particularly in conditions where they're not able to find other people or express themselves as openly as they would like to. And I think one of the things that is important for me to be here to be able to talk to all of you about is that that's the sort of thing that we want to do in collaboration with others. It's the sort of thing that we want to do with everyone who's invested in reducing HIV, in reducing STIs, and really building a stronger community for gay men around the globe. So with that, I will finish, and I think we're going to have questions. Okay.
Thanks, Alex. We've got time for a couple of questions, if you'd like to come up to the microphones.
Hi, Dr. Dihaden from southern Minnesota, practicing physician. My question is, what do you guys plan to do to give the message to the gay community that PrEP is not the answer? PrEP is not that doesn't give you a free hand to have condom-less sex, in other words, a bareback. A lot of people have that impression once you're on PrEP and you don't need to worry about anything. And that is one reason we are having a lot of the resurgence of syphilis and other STDs. And if gay community doesn't want to be blamed as the source of those drug-resistant the gonorrhea and things like that, then we need to give the message to the community.
Thank you. I think fundamentally, it's our responsibility to provide gay men with as much information as possible so they can make informed decisions about their health. We're not their parents, we're not their government, and I fully believe in gay men's self-determination and autonomy over their sexuality. And fundamentally, we have to decide whether we see gay sexuality as fundamental to one's humanity to determine for yourself what you want to do with your body, and how you pursue pleasure and intimacy, right? If that's fundamental to human rights, then we have to start there. We have to meet gay men where they are there. And for so many men who've taken PrEP, the anxiety that it has alleviated from 36 years of living in desperate fear of a disease, it's been transformational. The mental health benefit alone to men in regards to PrEP is something we could never have hoped for. And so I think it's important to be able to provide gay men with as much information as possible, to provide them with their options for STI prevention and treatment, and then allow them to go out into the world and make their own decisions. If they test positive for syphilis, we treat them. We educate them. If they test positive for HIV, we support them. We get them on treatment. That's the way that we engage and build a community. Blaming and shaming is counterproductive.
Not in a way of blaming and shaming, but just to be responsible, play responsibly. That kind of message, would you be willing to give?
As I said, I think it's fundamentally important to allow gay men to make their own decisions about their bodies. We've had this argument about women for centuries, and we still see governments deciding that governments are going to make decisions for women's bodies. So I think fundamentally, if we believe in a human being's ability to determine for themselves what they want to do with their body, it's not for me to call them responsible or irresponsible. It's for me to respect you, to make your own decisions. And if that decision results in a healthcare outcome that I don't like, I'm still going to give you healthcare. We're still going to pay our taxes to give you healthcare. We're still going to support you and embrace you as part of our community because you're not a bad person for what you did. Thank you.
Thank you, gentlemen. We have one more.
I just think this is incredibly interesting, and so I just have a couple of questions around privacy and data. So we do something similar, but we do it within a research environment, so we get consent when we're connecting folks, and then we're monitoring them, and there's a lot happening, whereas the app, based upon what you're saying, I'm sure is much more open. And so I'm wondering, for example, does somebody opt into being, so for example, if I say that I'm positive, do I then also say, and people can contact me about that? So sort of how is that managed? And then do you have any data about how it's working, and which I think is tricky because you don't want to be Big Brother and monitor, but at the same time it would be really cool if you could talk about some outcomes. So what does that all look like?
Yeah, so in terms of the first part of your question, I think, so in terms of one's profile within the app, you can select to disclose your HIV status, and so that will be public information, that when someone looks at your profile, they will see it. And that's a decision that everyone sort of determines for themselves whether or not they want to be that public. I think one of the things that I didn't mention that we're able to do is that if you're HIV positive, there's a search function that allows you to search for other HIV positive individuals. It doesn't allow negative men to filter out HIV positive people, but it allows HIV positive men to find one another, because we understood that it was important to be able to foster a community of HIV positive men. And so we wanted to provide that option. In terms of the data, we are equally interested and excited about the data. Much of that's being worked on now, so I would say it's forthcoming.
Okay, last question. Please make it short. Oh, right. Good.
That's it.
A couple of questions turned into one, which is good. Thank you, everybody. Thanks very much, by the way, for a very lively session there and a good conclusion. And I invite anyone who's interested to stay on for the debate. Thank you.